tonight's webinar. My name is Sarah Miller, and I work here at Child Care Aware of America. I'm the Senior Policy and Advocacy Network Advisor here, and I want to thank you for joining us this evening. Couple of quick things before we get started with tonight's webinar. If you have any questions throughout tonight's webinar, please put those into the question box as we go along, and I'll be sure to go through all of the questions towards the end of the webinar. If we do have too many questions and we're not able to get through them all, we'll be sure to follow up with you via email. Tonight's webinar will be recorded and put on our website. And then I know many of you have questions about certificates, and we're actually going to be handling certificates a little bit differently this month. All of our certificates will be available to those who participate in the live webinar and participate in more than 75% of the webinar as it is recorded. Now, in the past, we've had you email me and request certificates, but from tonight out, we are looking at a new system where we're going to automatically distribute certificates, and you will not need to email me to request the certificate. So if you are eligible to receive a certificate, it will be sent out to you within the next week. At this time, I would like to introduce Gerard Costa. He will be hosting tonight's webinar. He is the founding director of the Center for Autism and Early Childhood Mental Health at Montclair State University. He is a clinical assistant professor in the Department of Psychiatry at UMD-NJ, New Jersey Medical School, and serves as a trustee and graduate school facility of Interdisciplinary Council on Development and Learning Disorders. He serves as a consultant to 0 to 3 and sits on several nonprofit boards and the Build NJ committee. He received his PhD in developmental psychology from Temple University. So at this time, I'm going to hand it over to him, and we'll start our webinar. Thanks for joining us.
Thank you, Sarah. Well, hello, everyone. I look forward to the chance to speak with you about this topic. And just hold for 1 second. I lost the screen, so I'm going to check with Sarah to just be sure I get this. You know, Sarah, I don't see the screen.
If you just pull up your PowerPoint presentation, we can see your screen right now.
Oh, you can? Well, I can't, so I'm not sure what slide I'm on. Is there a way I can see it as well?
You should just be able to pull up the PowerPoint from PowerPoint itself, not in your internet browser.
I gotcha. Okay, let's see. We'll try that. So sorry for the technology problems there, folks, but what I'd like to do is just review a bit about what our plan is for this evening or this morning, depending on where your time zone is. So I don't know if you can see this, but I have the slide on that describes what our plan is for this session. So I hope that we'll review the early signs of autism, discuss some recent reports about the rise in children given this diagnosis, and try to really think about an inside perspective of how children and adults with autism might be experiencing the world. I hope we can have some discussion, mostly, Sarah. I know we'll field your questions, but I hope we can address as many of them as possible in the hour we have. And I hope I can end with some discussion about the range of interventions available and really to talk about the notion of autism acceptance. As you know, April was Autism Awareness Month. So before I begin, if we can ask Sarah, we'll just do a quick survey of the participants to see what who are represented among the audience. So I hope you can see a quick poll that appeared on the screen for those who can't. What we're asking is to indicate if you are an educator, and you can select as a parent. You might be a parent and a professional, but the 5 possible responses are: I am an educator, I am a mental health professional, I work in some allied pediatric discipline, you are a parent and professional, I'm sorry, there's the option, and you are a parent, and choose one. So I think, Sarah, we can either see the display of the respondents or verbally report on them.
everyone just a few more seconds to fill out the poll. We have about 70% of responses right now.
Great, great.
Okay, great. Well, then I'll show this poll here just so everyone can kind of see who's on the line today.
Great. Wow. So 85% of you are have categorized yourself as educators. 5% are parents. 7% in some allied pediatric discipline. I suspect that might be an occupational therapist, physical therapist, speech and language pathologist, perhaps some pediatric medical discipline, nurse, pediatrician, and 2% identified themselves as parent professional. I see no one from my field is on here, so I'm the only mental health professional that's part of this. So that's great to know what our group is, and I particularly am pleased so many educators have joined us. So let's continue to go through the presentation, and with our next slide, I really just provide you with a basic overview of what we understand autism spectrum disorder to be. As you know, it's referred to as a spectrum disorder, and that is a relatively new term suggesting that, in fact, that each child, each person given this diagnosis differ in many, many ways, although there are some common elements that define it as an autism spectrum disorder. But we do recognize that it is a neurological disorder with likely genetic origins that affect the structure and the function of the brain. And it controls reasoning, problem-solving, memory, communication. We are learning much more about the way it affects sensory processing and even our states of regulation and our capacity to use our motor systems, so motor planning. What makes autism as a spectrum of disorders, or that even though there are differences among the persons given this diagnosis, the next slide really talks about the common elements that exist in all cases of autism spectrum disorder. And I think, Sarah, you still have control, or can I have control of this?
I pulled it up because it didn't look like we could see your slides, so I was kind of managing the slides here on our end.
Good. So if you could do the next slide then. And so the next slide talks about the 3 core indicators of what autism spectrum disorder is. So some social impairment, that means some difficulty or some difference in social relationships. This can manifest itself in differences in eye contact, in social approaches, in concepts that are now being understood as joint attention or shared emotional connection. So some social impairment, some impairment or difference in communication, and that includes both affective and gestural communication, as well as vocal and verbal communication. So, for example, we know that many persons with autism have difficulty in reading social cues and reading affective and gestural systems. I'll actually touch on some of the research that suggests what may be going on for persons with autism. And finally, the final indicator are the presence of stereotypies or repetitive behaviors. And these can be the more familiar kinds of things you're familiar with, like hand flapping or toe walking, but they may also refer to other behaviors that are sometimes looking like they are obsessional or repetitive behaviors. So we'll talk about that, but the neurological profile that actually exists in persons with autism is much broader than just focusing on these 3 elements, but these 3 core indicators define the spectrum. Next slide. Stephen Shore is a remarkable adult with Asperger's syndrome, an author and advocate, and he famously has said, if you've met one person with autism, well, you have met one person with autism. And that really reminds us critically of how important it is for us to get a sense of each individual's profile who's been given this diagnosis. Next slide. So the other thing that I think is important to keep in mind for all of us, and I think this is particularly true, and I think the parents in this webinar can teach us about this, that autism spectrum disorder does not simply involve the child or the diagnosis or classification of a child, but really the entire family and the community. surrounding that child and family. And so I'll talk a bit about, in a moment, about this whole notion of thinking about autism, not necessarily in terms of becoming more aware of autism. I think that certainly is necessary, but really talking about each person with autism as really requiring both our acceptance and our adaptation. And so we'll touch on that, I hope, in a short while. Next slide, Sarah. So I think the prevalence data may be data that you are familiar with, but I think it's important to review because you may be aware that recently, in March of this year, a revised report was issued by the Centers for Disease Control in Atlanta. And I think for those who might hear these data, they are concerning and alarming, especially, I think, for families who are planning to have children and are seeing these data. But just to put this in perspective, when I was first involved in early intervention work, that's with children birth to 3 and their families, the data back in that time, 1985, 86, 87, were that autism, the prevalence of autism was estimated to be about 1 in 1,500. So a very large number. In fact, many other genetic or neurologically based disorders had a much higher incidence than autism at the time. But the field, there were repeatedly over the years anecdotal reports from those in the field and in my own experience that those numbers seemed to be growing and that the prevalence rates were higher. And in 2007, the CDC, the Center for Disease Control, looked at 14 states carefully with a pretty strict protocol on assessing the existence of a child with autism diagnosed by AG, and found that in the 14 states studied, the prevalence rate was now at the time estimated to be 1 in 150. In my own state, by the way, of those 14 states studied, New Jersey had the highest rate of 1 in 94. But in 2009, 2 years later, the National Institute for Mental Health re-looked at that data and felt that, in fact, cases of autism were buried in the data and had not been identified properly, and they estimated it to be 1 in 100. Now, at the time, of course, that was remarkably concerning. And then in March of last year, 2012, the CDC looked at those 14 states more carefully again and found that autism was being reported by age 8 in 1 in of 88 children, and in boys 1 in 54, which was remarkable. In fact, New Jersey was the highest at that time. Next slide. But what I think has really alarmed many people in the field, and certainly many families and many service providers, is that just this past March, the CDC released a new report using a different methodology. In the prior report, 2012, 14 states had been looked at very carefully, and detailed clinical reports were required to determine that a person was given a diagnosis of autism. But in 2013, they reported on survey data gathered by telephone that were collected in 2007 and 2011, 2012. And 100,000 parents responded to the survey, although that number represented less than 1/4 of those who had agreed, who were called and who contacted. The 100,000 were those who agreed to answer the questions. And based on those data in 50 states now, not just the 14 cluster states, they reported now that by ages 6 to 17, so they also raised the target age, 1 in 50 children were diagnosed with autism spectrum disorder. That's really a 2% rate. Higher, by the way, than most states report incidences of child abuse and neglect. So these data were certainly alarming, but I want to caution you in terms of the meaning of these data, because I think all of us recognize that there's greater awareness, that there's greater sensitivity and a better early identification, better assessments of children. I think there's a greater awareness, so families are much more likely to identify a concern that might fall within the autism spectrum with your child. But I also think that there are many, many cases that might be given the diagnosis of autism in part because it can trigger a multitude of services for families which are desperately needed. So we don't know yet what these data represent, except I think all of us recognize that even given the greater awareness and greater ability to identify children with these developmental concerns early on, we still recognize that there may be an authentic increase in what is going on. And I think the answer as to why is still under research and still eluding us. Next slide, Sarah. So what I wanted to do was quickly review what we think are some of the best ways of identifying those early signs of autism. And I drew much of this from a wonderful book by Nancy Wiseman called Could It Be Autism? And Nancy, as a parent of a child with autism, and developed the First Signs Initiative. And I think these are very helpful benchmarks. And I'll go through them quickly just to let you know that we are beginning to even look very carefully in the first year of life for early signs. Traditionally, autism had never been diagnosed prior to age 3. And we now, I think, are feeling confident that with a careful examination and observation, we could really see some of the early signs, or at least make an effort to do further evaluations as early as 8 to 12 months of age. So, you know, it's helping us better identify the early needs of children. It also, I think, helps us recognize that while certain behavioral and developmental indicators might suggest autism, it also may simply suggest some other developmental difficulties that are very amenable to change and intervention. So let's just quickly go. By age 4 months, we should expect to see a child follow and react to bright colors, movement in objects, turn towards sounds, look at and show interest in people's faces, certainly smile back and even laugh in interpersonal exchanges. By 6 months of age, we should really see that laughter grow into real joy, smile often when playing, coo or babble when happy, cry when unhappy. Next slide, Sarah. At 9 months, there should be a lot of smiling and laughing when looking back and exchanging the back and forth affect and gestures that really occur so naturally in most mother-baby, father-baby dyads. There should be back and forth sounds that even become more imitation-like, exchange back and forth gestures with you, such as giving, talking, reaching. By 12 months, this is really when we should see a lot more affect and gestures growing to get their needs met. They would point to objects using their finger, reaching for and waving, playing peekaboo, pat a cake, or other kinds of social games, make repetitive sounds, typically monosyllabic, mama, baba, dada, nana, and so on. Turn to the person speaking when her name is called. We often talk about this as social referencing. Next slide. At 15 months, these exchanges should really increase in terms of back and forth smile, sounds, and gestures in a row. Dr. Stanley Greenspan, who I'll touch on briefly, a wonderful child psychiatrist who's written extensively about autism spectrum disorder and other developmental disorders, talks about a concept called opening and closing of circles of communication, where the child initiates something or the child does something and you respond back, and then they in turn close the circle, and those exchanges by 15 months can be 20, 30, 40 in a row. They're just the sustained reciprocity and engagement. Certainly by then we should see a lot more growth of gestures to draw attention to something, pointing to third objects between the two of you, using different sounds to get their needs met, draw attention to something of interest, and certainly begin to even understand more and more words, particularly those words that have greatest meaning for them. Next slide. By 18 months of age, these gestures are actually giving rise to the beginning of some words, and so the child may begin to use words, repeat syllables, combine concepts like want juice or more milk or more daddy or pick up. Use at least 4 different sounds, and these certainly are related to the child's growing auditory capacities. Use and understand at least 10 words. Show that he or she knows the names of familiar people or body parts by pointing to them or looking at them, and certainly begin to do simple pretend play like feeding a doll or stuffed animal. At this point, the early pretend play really will be to imitate actions they have seen with objects that look very much like the pretending they're doing. So a pretend doll for feeding, or a pretend picnic set for eating something. Next slide, Sarah. By 24 months, the pretend play is growing, and so now they'll actually begin to play out some dramas and longer, more elaborate themes. So this time the child will be fed and then maybe put the doll to sleep, or between 24 and 30 months we'll actually see the child even begin to do some familiar themes with the child, like changing their diaper and taking, putting them in a small baby carriage and taking them for a little walk. And you can see that they're using more words repeatedly. They enjoy some time with their children and playing with children. They're still not playing very cooperatively, but they're playing next to other children and showing an interest in children. And they certainly have object permanence. They look for objects that they know are there even when they don't see them. Next slide. And so the next slide really just sort of ends. I'm going to stop at the third year because we want to move on to some other topics. But we know that by 36 months, a lot is happening with children. And in the past, oftentimes parents would come to practitioners with concerns about their child not speaking sufficiently, and their child having used words and have lost words, or their child is not engaged in pretending. And by 36 months, these things are quite evident. But as I'm suggesting, some of these earlier indicators need to be looked at carefully as well. But by 36 months, they should really be enjoying a lot of pretend play and even talking on behalf of dolls or action figures. This is where we actually begin to see them play out some emotional themes. That old warning that if you want to know how you speak with your child, look at the way your child begins to speak to their dolls in play, and you'll get a sense of what the child is witnessing. They will use more thoughts and actions. They'll certainly be able to play through themes and even begin to have reasons for why. So the baby is going to sleep because they're tired, and the baby is hungry, so you have to feed a bottle. And they'll begin to answer those W questions, as we said. And they'll talk about things that are both present and in the past. And of course, this is typically a wonderful time for us to begin to learn about what children do when they're not with us, what happened when they were at preschool or with Nana. So those are some of the early developmental markers that we would look for. But as we know, there are times that these things don't occur. And when children have been given the diagnosis of autism spectrum based on those 3 hallmark areas I mentioned earlier, social relatedness, communication, and some stereotypies, it does suggest to us that there is some underlying neurodevelopmental derailment. Now, the reason I say neurodevelopmental again is that it was mistakenly believed many, many years ago that autism was really related more to faulty care. And while we know that severe deprivations of care can really result in some concerns, we know, in fact, that autism is not the result of poor parenting, or as Bruno Bettelheim would say, the refrigerator mother, the cold, aloof, distant parent. Those are absolutely not the case. It's more neurologically based. So I'm going to quickly go through some ideas. Next slide. And Sarah, I'm going to go through these rather quickly. So if you can move to the next slide. I want to touch on just a couple of differences we've been learning about, and I will move through these slides quickly. We are learning, next slide. We are learning really that for some children with autism, the first year of life is really a significant year in terms of brain growth and brain development. Some of you may recall that you've gone to pediatricians or you've gone to family physicians or child psychiatrists, and one of the things they often do is measure the head circumference. It turns out that for many children in the first year of life, children who were subsequently diagnosed with autism, it seems that their brain growth rate is very accelerated in the first year and then slowed down. Next slide. And so the idea may be that in some cases for children with autism, this excessive growing of the brain may not permit the kinds of interconnections that are needed among brain areas for there to be typical development. The good news always is that therapeutics and intervention programs can still address those connections, but there may be this neurologically based difficulty in forming those connections. Next slide. I also think there's a fascinating set of research that's talking about something called mirror neurons. And this is where we humans have this remarkable capacity, first identified in macaque monkeys by Giacomo Rizzolatti, a physiologist who was working in Russia at the time. And he discovered that we persons and we primates, including primates, but also we humans, have this ability to have our brains actually altered in the presence of other brains. So the interpersonal neurobiology of autism is remarkable, because what we are finding is that there are children who have been diagnosed with autism who may not have the neurological response to others' affects and gestures. So to give you an example, if you were watching someone smile, you would automatically start smiling yourself. If you were watching someone eat a slice of pizza, and we could measure parts of your brain, the parts of your brain involved in holding the pizza and the parts of your brain involving the movement of your lips and tongue would actually be activated, showing that your brain is mirroring the actions you see in others. It turns out, next slide, that there are some children with autism where this may appear to be less available, that their mirror neuron systems are less available. Next slide. I think one of the most fascinating areas has been the way in which children with autism scan visual objects. Next slide. So Dr. Amy Klin, originally from Yale, now in Atlanta, looked at the way 2-year-old children with and without autism looked at certain visual stimuli, visual arrays. Next slide. And he found out that when children looked at the figure on the left, they would have 2 stick figures, one on the left, one on the right. And if you can imagine those stick figures moving with little lights, points of light at each of their body joints, and there was a sound that was playing, and it was playing in movement, in synchrony with the sound and moving forward, versus an image on the right side of the screen that had the same image, but the image was playing upside down and backwards, so it wasn't synchronized with the sounds. And he tracked how children with and without autism just scanned, visually tracked these objects. Next slide. And Ami and his team found that for the 21 toddlers who had autism, they really showed no preference between those figures, while the 39 non-autistic children clearly preferred that upright, synchronized figure. But when he added synchrony to that figure, that upright figure, when he played pat a cake and the stick figure, were clapping their hands so that the points of light actually collided at the sound of the clapping of hands, this helped really for those children. So what the implication of this has been is that many times children with autism may not pick up certain visual cues that others do. And by the way, this helps us once we know that children maybe are not so good at reading facial cues or reading social cues and gestures, the meaning of gestures and affects, and that helps us in terms of how we develop interventions. Next slide. So Ami and his team are actually doing much more research, looking more carefully at this, and he hopes that in the future they can understand how early on we can help retrain and reorganize the visual system to look in more precise ways. Next slide, and I think we'll skip the next slide actually, we'll skip that. So I'm finally going to talk just about another set of ideas, next slide, about the role of emotion in autism. Now I recognize for some of you these slides are probably a little bit instructional looking. They look like a course in neurology, and I hope I won't scare you away. But in our brains, we have, if you can just play the prior slide for a second, Sarah, that we have a top layer of our brain called the cortex, and right below the cortex, above the roof of our mouth, are a series of structures known as the limbic system. That are a set, there are a set of structures in that location that are most important for our affect, our gestures, or reading of social cues, or reading of faces. And so now if you can go to the next slide again, Sarah, if you can see those small little brown circular, they're really almond-shaped, balls at the end of those brown tubes, that's the amygdala, and surrounding it is the hippocampus, which is a part of the brain most involved in processing memory. Next slide. Well, it turns out that this amygdala, this part of the limbic system, is critical in typical development for helping us to appraise social situations and read social cues. So when strangers come into the room, when new events happen, this activates us in a way that gets us aroused and alerted for action. It actually triggers a fight or flight response. Next slide. And so Daniel Siegel, who's a wonderful neurologist and neuropsychiatrist, has even described this, that if you imagine your hand is like your brain, and that part of your brain most involved in emotion is your thumb, and that's where the amygdala and that hippocampus is I just showed you. And then you cover your thumb. I hope you all are holding your hand up, putting your thumb in your palm and covering your thumb with the top of your head. It's as if that's like the brain. There's a right brain and a left brain, the hemispheres, that when that amygdala gets activated and overwhelmed by stimuli, next slide, it's really what he calls, you flip your lid. That the amygdala actually disables some of the higher level thinking just momentarily. Well, what we are learning about persons with autism is that sometimes they are overwhelmed by events in the environment, lighting, sounds, facial expressions, the movement of others in the world, that others might not be as disturbed by. So they might engage in behaviors that look unusual, like they might screech, they might flap their hands, they might run, they might appear disorganized and really in so many ways anxious. It's really a possibility now we're learning that the amygdala of children is over-responding to events that others find typical. And this gives us a very important insight into the fact that children with autism often have much greater abilities, but momentarily are disabled because we are not, in a sense, helping them adapt to the world because we don't get it. We often, in fact, urge them to do things and confront stimuli that are difficult for them to deal with. Next slide. So what I really want you to think about as we move forward is that children may have these neurobiological vulnerabilities, children with autism, that render typical experiences into ones that are felt as powerful and dangerous, and they overwhelm them. Next slide. So what really we have to do is that really think carefully about what children with autism are like in responding to the events in our world. Next slide. So in a way, our task for looking at each child is to really get a sense of that second bullet here. What are their individual differences? What are the ways in which they respond to the world? And what are the ways in which we have to come to know their profile? Next slide. In fact, Sarah, skip this slide for one moment and go to the next. So a good colleague of mine here at Montclair State has developed a wonderful instrument to help us as practitioners and parents develop a self-statement from a child's perspective. And that means, how do we imagine the world through the eyes of the child? Next slide. So she published this article with a parent who happened to be a developmental dentist, a DDS, and a certified occupational therapy assistant. It was published in this journal. And what it does, next slide, is it encourages parents to really think about developing a way to understand their child from the inside perspective. And in fact, I provided you with a brief outline, next slide, to think about in terms of wondering about what your child or a child's sensory system is like, their motor system is like, how they are developing in terms of their gross motor and fine motor control, their communication abilities, certainly their intellectual development, and critically important, how they are engaged in relationships. And based on this kind of self-template or profile, we can begin to try to think of our role in helping children and families affected by autism, to think about how we can get to know each individual child. So this one slide, and again, I know this is a quick review of it, but this one slide is an attempt to try to say that the field of autism requires that each child be understood as this unique template or this unique profile of capacities. So I'm going to just skip, as I said to you earlier, I'm going to skip a couple of slides in advance. And if you can get to the slide where it says, for every emotional, this one. So we know that when children have some of these neurologically based differences I've suggested, that their visual scanning might be different, that their brains may be actually functioning in different ways, that their amygdala and their limbic system is responsive in a way that activates them more than they need to be. We can also expect that those neurological states result in both emotional experiences that are felt as disorganizing, and also body states that are felt as discomforting or uncomfortable. For this reason, by the way, we talk about the idea that it helps us to imagine the child with autism as sometimes experiencing a kind of anxiety. You might not be surprised to discover that for many children with anxiety, there is often a co-occurring diagnosis, for children with autism spectrum disorder, there's a co-occurring diagnosis of anxiety. So the next page actually is kind of a little cartoon drawing to remind you that each child has their own, the next slide, has their own, little differences. And I always want to emphasize that all of us have these differences. So I know many of you may yourselves have certain preferences for certain kinds of clothing you wear. Some of you may hate those tags on your shirt. Some of your children may have hated certain fabrics or dislike the little seams on their socks or anything. We know that each child, each adult, each person, with or without diagnoses, has a unique profile, and that's really one of the final messages I want to leave you with. So what I'm going to do now is just ask Sarah if she can move all the way, Sarah, to the slide that's number 48, and that's the one that's on the approaches. So how do we help children with autism and with these concerns? Many of you may know, and what I've tried to list are 4 classes of intervention. The most common is this applied behavioral analysis, and it's where they focus on the preferred or identified target behaviors a child is asked to develop, and then using reinforcement strategies and some prompting and direction in a very prescribed way. They try to break down larger tasks into smaller bits, and then to help children form these behaviors through using rewards or reinforcements. And this can include things like making more eye contact, sitting more in the chair, spending more time on task, even some verbal prompting using language to make requests, identify who they are, and so on. There are, however, a growing group of approaches, one in which that we train and educate people here at our center and nationally, that's been trained through the organization that was mentioned in the introduction, that was founded by Dr. Stanley Greenspan, ICDL, the Interdisciplinary Council on Developmental Disorders. And those are focusing on multidisciplinary approaches to helping children with autism by understanding their developmental progression from early engagement to regulation, to engagement, to two-way communication, and also recognizing the importance of emotion, those limbic system structures in organizing brain development. So those affect, relational, developmental-based approaches, many of you may have heard of approaches called DIR or floor time. Those are those strategies. I find them to be comprehensive, but again, there are many, many approaches that all of us, I think, collectively need to use. And there certainly are now many, many approaches that occupational therapists are teaching us about, and that really involves becoming more aware of the sensory systems and profiles of young children. So if you can go all the way to, I think, the slide that begins with selective strategies. Sarah, that's about two more, I think. Right, next one, sorry. So I think that what we have learned is based on this growing understanding of autism as this neurodevelopmental concern, and one that may render children, because of these brain changes and sensory changes, may render them less available. We have to think more carefully about how we, both ourselves and the environment, create climates where they can belong. So I always think that when we first meet a child, families know their child best, to really ask and be taught by the child. I've also found that for children with autism, affect and gestures are critically important. So we often demand verbal responses from children who are not verbal enough. We should be using affect, fewer words, and shorter sentences and longer pauses. I call this the 4 L's. Less language, longer latency. Many children with autism could benefit from picture supports, visual schedules, advanced notice of transitions that are about to happen. Next slide. It's so important that other organizations that you might be working with besides the primary school are worked with together. I've also been encouraging folks to be aware of their own body movements, the loudness of your voice, touch, and eye contact. I hope that the educators and all of you are familiar with a wonderful author named Dr. Paula Kluth, K-L-U-T-H, who has written a wonderful book called You're Gonna Love This Kid, about inclusion with children with autism. I think the notion that all children with autism can be fully included requires that we think carefully about how we really adapt our environment and adapt our approaches. Next slide. So for example, we need to be fully aware that many children with autism are sensitive to lights, fluorescent lights in particular, sounds, touch, smells. Paula Kluth talks about a child who was so sensitive to a perfume worn by a classmate that they consulted with the entire class, and that classmate offered not to wear that perfume because she knew it was a trigger for difficulties in that child. We certainly know that there are many triggers for challenging behaviors, and we have to really develop strategies that help children. For example, why is it that some children who are sensitive to light can't wear a hat in class? Or why can't they wear sunglasses? There's a movement that really is advocating for inclusion called neurodiversity, which is talking about how we all have differences. And so autism is not about just becoming aware of it, but accepting that our goal may not be cure in the formal sense of the word, but in understanding each of us have differences and helping children with autism adapt to their differences. And so the next slide really is just one more set of strategies. I'm sorry, the one after this, Sarah, and that's it. So it's just some more sets of strategies. Sarah, one more slide. Yeah, about making adaptations to the physical environment, and I suggested some of these. You can take a look at that. So I know I went over a bit that I wanted to. I know we started a bit late, but I hope that in this brief time I've been able to give you some sense of what our field has been learning about children with autism, how we can best understand them from the inside out, and how we can start thinking about the comprehensive ways to help them and their families. So let me stop there, and Sarah, I hope you can help the discussion go for at least a little while.
Okay, great. Well, it looks like we have some questions coming in here, and I just want to remind everyone, if you have any questions you'd like to ask, you will see the question box to the right-hand side of your screen. So the first question here is, will this webinar be archived somewhere for review later? And I just want to remind everyone that tonight's webinar is recorded and will be posted on our website. And we'll also send out a link tomorrow with a link to the recording, so you'll have access to it. Okay, so one of the questions here is, how may we differentiate slower developmental growth from autism spectrum? Will they show signs?
Well, I think in many ways the best strategy is to be as knowledgeable as you can of typical developmental milestones. Now, we are mostly familiar with cognitive milestones, but there is a wonderful way of thinking about early emotional and social development that I think is one of the best ways to really determine if a child is meeting those milestones. And it's a scale that was developed by Dr. Stanley Greenspan and his colleagues called the Functional Emotional Assessment Scale. And there is actually a version of it that is published and very easy to administer, and it's self-report by parents, and it's called the Greenspan Social Emotional Growth Chart. And it goes through 6 stages of emotional development from birth to 4. It talks about the child's ability to engage in regulation, the child's ability to form an engagement and an attachment, the child's ability to begin to engage in reciprocal back and forth behavior. The 4th level is to gauge a child's capacity to have longer and longer sustained chains of back and forth, what I called before opening and closing of circles of communication. The 5th stage, the beginning to use pretend play and language as the emergence of symbolic and representational thinking is growing. And the 6th stage is when those emotional abilities, those representational and pretend abilities, words and pretending, are used to start looking at emotional themes, dependency, aggression, and so on. So those 6 stages of emotional development, known as the Functional Emotional Developmental Scale, I think are the best ways to determine if your child is meeting the milestones early on. And by the way, the early signs that I listed before by Nancy Wiseman, I actually think those early signs built upon those 6 stages of emotional development.
Okay, great. There's been a few questions coming in regarding getting a copy of the PowerPoint slides. And along with the webinar recording, we are able to post the slides so we can get those up on our website as well. So once we send out that link, it will have a link to not only the recording but the slides as well. A great question just came in here. How should we deal with a parent that is unwilling to have her child screened for developmental delays? We have met with the family and went through the delays that we are seeing, but they are in denial.
Right, right. I have to say, that's a great question. It really is. And over the 30 years I've been in early intervention and early childhood, I've certainly worked with parents and been with parents where their awareness of their child's difficulties, you know, were difficult to come to. And I think the point you're making, oftentimes I've worked with staff who feel that they're seeing the concerns clearly, and it leads them sometimes to become frustrated and worried, particularly worried about the child. So I'm going to give you what I hope are some 2 helpful strategies. One is to be patient and have the conversation more than once. I think oftentimes the first time you bring up a conversation that your child may need more of an assessment and an evaluation, because for the most part there are only very specialized disciplines, psychiatry, psychology, pediatrics, medicine folks who can do the formal diagnosis. So I think the first time is to sort of raise the issue, and if the family responds, I think it's important to sort of follow their lead initially. I know, by the way, that that's not always easy to do or even possible, depending on how old the child is. But I found that if families are forced or feel coerced, it might be more difficult for them to address it. I think the second strategy is to really try to have empathy for the parent. You know, in an earlier version of the slide presentation I was preparing, but I knew I didn't have time, I actually had an entire section on what is it like for families to be facing the possibility of discovering that something is up with their child. So I'm going to suggest a kind of way of having a conversation. I often talk about this with my staff in terms of having a courageous conversation. Almost no one wants to speak with parents about something possibly being up with their child. Many times family members will even normalize things. Oh, your brother didn't talk until he was 5 anyway. Einstein didn't talk until he was 7. You know, folks will really normalize it. What I have found is so helpful to do is to try to imagine what it's like for them. And so when you talk with them about it and they say nothing is wrong, I would really just try in that moment to say, it must be so hard to even think that something might be up. I would then often try to say to them, would it be helpful or would it be okay if I gave you some stuff to read on your own time that you might find helpful? I think giving them a chance to mull over it on their own, but without retreating from your worries, is an important thing to do. I think it's important to follow their lead. I think a third thing is, I think it's helpful to link every discussion you have about your concerns about a child, and you don't necessarily and should not necessarily initially use the word autism. I think it's important to link those early discussions to sensory-based issues. I see he gets very excited when he hears noises, or you see when he gets excited he flaps his hands. I think it really is hard for him to know how to express his excitement. Try to link it to some of the things you are seeing. Now, I know this is a much longer conversation I wish that we could have, but I think if you can do those kinds of things, kind of monitor yourself and, you know, say to yourself, this has to be a conversation we have a number of times, not just one time, and follow their lead. You know, try to have empathy for what it might feel like. This must be so difficult. Let me share some things for you to mull over on your own. And the third thing is to try to, you know, to really kind of link it to the child's behavior. Those might be helpful strategies. I've almost always found that at some point a parent will come back and say, you know, I really am worried about my child, and I think what you said may be the case. So I hope that helps.
Okay, great. It looks like we have time for just a few more questions, but we have a great question here. It's kind of a two-part question. The question is it possible for a child with autism to thrive in childcare? And how do you make your environment functional for all students when you have a classroom that have children with autism and without?
Right, right. I think the first question is a great one. I think that children certainly can thrive in childcare, but I do want to tell you that the childcare has to be one that is very open to the individual differences that children may have. And so, for example, there are some children who have some problems in self-regulation, and if we were to force them to do circle time and sort of every time they sit down, they would have to sit in the same way as everyone else, I think we're helping to create a frustrating experience. So, for example, centers that I've worked with that have wonderful knowledge about children and their differences, particular children on the spectrum, will often have occupational therapists who will support them. And so occupational therapists will sometimes recommend certain either devices or experiences. Some of you may be familiar with this, for example, the circle time for one. Many children who have sensory difficulties, who have problems in balance and body and space issues, sometimes are helped by these sitting pads that have uneven surfaces on them that the child can rock back and forth on, that give the child some vestibular movement and some tactile input that help the child stay regulated. So we may need to help adapt some things to the child. We may need to have areas and devices in the room that, with the guidance of specialists, that child can use. Brushing protocols, kind of brushes for their arms, vibrating toys that help, ear coverings for children who are sensitive to sound, sunglasses or hats. I think that if we expect full inclusion to work, full inclusion is not simply throw the child into a room and they have to get used to the circumstances. We don't do that for physical disabilities. If a child is in a wheelchair and there's no ramp, we don't say to a child, "We'll find a way to get up on those stairs, or crawl into the room." We make adaptations, and I think we need to move in that direction. I recommend highly the book I mentioned, Paula Kluth. You're going to love this kid. It's a 2010 rewrite. It's a Paula Kluth, K-L-U-T-H, a wonderful book about how to adapt environments for children. The second question, I think, has also to do with this idea of creating a climate where all belong, and I think that's really where the individual capacities of children and the flexibility of programs to provide opportunities for all children in the classroom. And I'll give you one quick example. Many children who have difficulties with regulation, believe it or not, if they're old enough to know how to chew gum without swallowing it, love to chew gum. The movement, sometimes they're even given chewy tubes. They're kind of the stethoscope material, that's sort of heavy, thick plastic. Many teachers might say, well, if they want to chew gum, every child will want to chew gum in the class. And here's what I found. If you give other children a chance to chew gum in the class, those who really don't want to chew it, who don't need to chew it, they just want to chew it to be like everyone else, will chew it and spit it out. And you, of course, have to get parents' permission. But children who need it to stay regulated will be the ones to chew it. Just like not every child wears glasses. You may have a child who shows an interest in wearing glasses if a sibling wears glasses. Let them try them on. Let them, see what it's like. They'll only keep it if it meets a need. So I think we have to do some work on helping educators think a little differently about these adaptations that we're making, and in fact discover that even children without the diagnosis of autism have sensory needs that need to be met. So I think those are general strategies. Again, Paula Kluth has a great book to talk about these things. Maybe one more question, you think, or is time up, Sarah?
Well, we can do at least one, maybe two. We do have some really great questions in here. I know there are some questions we won't have time to get to tonight, so what I can do is I can pass these questions along to Dr. Costa, and as he's able to answer them, we can get back to you over the next week or so, but we won't be able to get through all of the questions tonight. But we do have a couple of really good questions I do want to throw out there if everyone's willing to stay on just a few more minutes. A great question here is, what age can a child normally be diagnosed with autism?
Well, I think I mentioned earlier that the prior belief, probably as late as the 90s, mid-90s, was that you wouldn't diagnose a child with autism prior to age 3. That's absolutely not the case now. I think we are much more able to look at earlier signs of autism. I don't know if I can specify the earliest age, but I think certainly you can begin to see some of the early signs of some kind of developmental disorder. Whether I would call it autism at that time is very speculative, because you may infer from what I've said so far is that many children may have sensory-based difficulties that render them less available, but would not be properly diagnosed as autism. I've worked with lots of children who, for example, are very sensitive to touch and have very great difficulties in self-regulation, it does not mean they have autism. But those early signs of some neurosensory differences, those early signs of those three categories I mentioned, of difficulties in social connections, difficulties in affect and gesture and communication, and some stereotypies, I think we can now identify those in many children as young as 10 to 12 months of age. And I think that that's not always the case, but for certain children who are showing those signs, we can absolutely see those children at a much earlier age than we've ever seen before. There's even been some research, and I'm not sure what state it's at, that's looked at the early motor patterns of children with autism. And I'll give you an example that Dr. Greenspan and others were doing a video archival study about 8 years ago where they were asking all families and practitioners who had children with autism to send them early videos of when the child was weeks and months of age, because they were beginning to hone in on the possibility that there are certain motor patterns. For example, there were many children diagnosed with autism who were crawlers, not on their palms of their hand, but they would upturn their hand so the back of their hand was on the floor while they crawled. So that kind of unusual motor pattern may be some early sign for some children. So there's more research in that, but I think even now most practitioners could carefully look at early signs as young as 10 to 12 months of age.
Okay, great. Well, it looks like we have run over our hour mark at this point, so I think that may be our last question for the evening. But I do want to thank everyone for joining us this evening. And those questions that we did not have a chance to get to, we'll try and follow up with those in the next week or so. But I do want to thank everybody for joining us, and this will be recorded, or it was recorded and will be posted on our website. And we'll be sure to follow up with everyone with the link tomorrow. Thank you, and have a great night.
Thanks, Sarah. Bye-bye, all.